This is Dr. Alice Lee. Welcome to our Facebook and Twitter live event. This is Dr. Jim Roberts. I'm happy to be sitting next to the legendary, iconic Dr. James Roberts, who's going to help me out, and Dr. Teresa Wu, an icon herself in many different ways, and a very accomplished emergency physician and educator. And I'm going to try my Mandarin, which is a little bit, poor, but 欢迎大家来周播脸书的节目。So that was just welcoming any Mandarin-speaking folks out there. And I would like to introduce my friend who will also give a short greeting. This is Dr. Axel Siu, and he is presently the president of the Hong Kong Hong Kong College of Emergency Physicians, and he's come here to help. Would you please welcome any Asian?
Yes, thank you very much for Alice's invitations, and we welcome all delegates, not only from Hong Kong, but also from all other Asian countries, Taiwan, Japan, Thailand, Singapore, to come here to join, to share all those you know about emergency medicine in Asia, and then share with our American colleagues.
Right, why don't you welcome them in Cantonese?
歡迎大家嚟到今次ASAP 2017喺華盛頓嘅一個嘅科學會議。咁我哋都歡迎大家所有嚟自所有亞洲國家，包括香港、台灣、日本、新加坡，大家一齊參加呢個活動，嚟到大家去一啲交流下，了解翻唔同各地嘅急症嘅處理嘅情況。多謝大家。
Thank you very much, Dr. Siu. Well, welcome everybody again. This is Stump the host event I have agreed to. I have a screencast on EMN called IQ, and the idea came to me because I've been a clinician for a long, long time, but I felt compelled to pass on all my experiences and what I've learned through all these years. And I learned about this flipped classroom idea, the fact that you can be assigned, let's say, a video or something to learn and read about, and then you go to your classroom, and then the teacher would spend more time kind of going over the material with you. So my screencast came out of that idea where you can combine audio and visual learning. The retention is much greater when you combine those two. That's the basis of why I did it in that format. So in the spirit of that kind of a learning experience, I wanted to see if my colleagues across the states here bring me a case where we can walk through it just like in my screencast, such as just like you would do in a ER on your shift, because you would meet the patient, you would gather information, you would do your test, you would have your differentials, and then you come to a conclusion either of a diagnosis or treatment. And so therefore I have Dr. Wu here who's going to present me a case and see if we can work through that together.
Okay. Dr. Lee, are you ready?
Yes.
This is a case that we saw recently clinically in our emergency department. It stumped many physicians with many years of experience, but I have faith that you're going to get this correctly. So we have a 57-year-old female that returns to the emergency department by private vehicle. She drove herself in because she's just been feeling more fatigued, weak, and short of breath.
So I'd like to see a set of vitals.
So we put her on the cardiac monitor, and her heart rate's about 56 beats per minute.
Okay.
Blood pressure is 140 over 96.
Yeah.
Her respiratory rate is 20 per minute with 100% saturation and afebrile.
Okay. So what does she look like just in general? Is she heavy? Is she little? Is she in distress? Or calm?
Great question. So she's lying in bed in no distress.
Okay.
She's actually joking around with you that she works for a major airline and that she never eat their food when you travel because it's giving everyone gastroenteritis. And she's just saying, I don't feel very good. Lately it's just, I've been more tired. I've been not having much energy.
So the chief complaint is really mostly fatigue and weakness, it sounds like. Were there any other symptoms such as vomiting, diarrhea, chest pain, shortness of breath, fevers, any of those other symptoms?
So when you ask her about vomiting, abdominal pain, diarrhea, chest pain, or shortness of breath, she says, no, nothing.
Not at all. What about recent travels? She's a flight agent, you said?
So she works for the airline industry, but hasn't been flying recently. She does food service. And lately she did take a trip from Arizona to California via vehicle, private vehicle. She drove with her son.
Okay. So what about recent changes in medications, or was she taking herbal supplements, anything like that?
So unfortunately, she hasn't been able to afford her medications that she is supposed to be on, and she has a list of them. She says, "Oh, it's in my purse. You can take a look."
Okay. Well, I'll go scrounging around looking for meds, but I guess I should ask her what her past medical history is. Does she have any medical history for which she was supposed to take medicines?
She says she has chronic back pain. She was in a car accident many years ago and has to use narcotics and benzodiazepines and muscle relaxants to help her sleep and to function in her day-to-day life.
So do we know what she's supposed to be taking at this point?
You have your nurse go through her bag, run through her list of medications, and check the MAR on the EMR, and also call her pharmacy to see what's been refilled before. And she's supposed to be on levothyroxine and also lisinopril. And she has purchased aspirin there in the past, baby aspirin, for her daily dose. She also has prescriptions for Percocet in her name, Oxy-IR, Flexeril, Robaxin.
Was she on any steroids? Did you look in her list? Any kind of steroids?
So no steroids at the time.
So at this point, I guess I would be examining her to get a physical exam. What do you find on a physical exam?
So what would you like to know on her physical exam?
Well, I guess I would like to know if she's flush, if she's pale, if she's diaphoretic, if she have temporal wasting, if she had these kind of red flags, I guess.
So she's not flushed and she's not diaphoretic. She's resting comfortably and her skin is warm, a little doughy, a little dry, but nothing really truly emergently remarkable.
How about no tenderness anywhere, abdomen or anything?
Abdomen is soft and non-tender.
No edema.
So she has some mild 1+ maybe non-pitting edema in her bilateral lower extremities. That's symmetric.
No redness anywhere, I guess?
No erythema or redness anywhere.
So, weakness and fatigue is a thousand things that can cause that. So I guess I would start at this point to order metabolic panel, metabolic workup to begin with, EKG, and then probably a chest x-ray just to start off.
Would you like a portable chest x-ray or
two views? If the patient is stable, I would prefer a 2-view. Any thoughts, Dr. Roberts, so far?
Well, it sounds like hypothyroidism.
Yeah.
Or at least that's a possibility. Also, those medications she's taking, fairly sedating medications. If she's taking them, it sounds like she's on long-acting or short-acting opioid, and muscle relaxant, and some other sedative drug. It could be just over-drugged.
Well, we have to also remember that she stopped taking these medicines, right? Because she couldn't afford them. So we have to think about, in terms of the differential, how a patient would be if they were coming off of something or withdrawing.
She doesn't look like she's withdrawing.
Right.
Does she?
Correct. So when you take a look at her, you're looking specifically for any signs of withdrawal, given her history of chronic pain use and benzo dependence, but she does not.
Does she have a palpable thyroid gland?
So you reach around the back of her neck and you use your fingers to try to palpate, and you don't feel anything really significant. You can feel that it's there, but it doesn't feel inflamed or enlarged or warm.
And what surgeries has she had?
So she's had her gallbladder removed, a cholecystectomy, an appendectomy, bilateral oophorectomy, and a hysterectomy.
And she's 50-something, you said?
57.
And she's never told she had heart disease, diabetes, or cancer.
Correct. She has been told she has high blood pressure and problems with her thyroid.
So we do have to add on the lab panel the TSH, the T3, T4. We need a urinalysis, perhaps. She's perhaps has an infectious etiology causing a different fatigue. And she was on her medication list. I guess I would have to look at it again, but was she on estrogen?
No, she was not.
How's her heart sound?
So we listened to her heart, and she has large breasts, but her sounds, you can hear them. There's no murmurs, there's no rubs, there's no gallops.
Okay.
Are they very distant?
They are distant.
Okay. And is it neck ring distension
Minimal JBD, bilaterally symmetric,
while she's sitting up?
while she's sitting up.
So at this point, I would grab my bedside ultrasound.
There you go.
And I would do a 4-chamber view to see if she's got a pericardial effusion.
Okay, so you go and you grab your bedside point of care ultrasound, and you wheel the machine over, and you take your phased array transducer.
Yep.
And sure enough, you do a peristernal long axis view, and she has 1 centimeter circumferential pericardial effusion around her heart. So we looked for signs of tamponade physiology on ultrasound, which included end diastolic right ventricular collapse and end diastolic right atrial collapse, which she actually had despite the chronicity of her accumulation of her effusion. So what were you guys thinking as the cause of her pericardial effusion?
It could be hypothyroid.
Right, or mixed edema.
Did she have pulsus paradoxus?
So in retrospect, now that we saw the pericardial effusion, we took a look at not only the cardiac monitor and the leads and saw a little swinging of her heart within it and changes in her conduction. And then in feeling her pulse, you could feel the changes in the waveform of her arterial pulse as it was being propagated forward.
Oh, interesting. So did we get the TSH and T3-4 back at all in the ER?
So as you're waiting and marveling at your brilliance of looking at her heart with a bedside ultrasound, her TSH comes back over 200.
Oh, cool.
And her free T4, the lab had to call and say, I'm not sure this is detectable, but I think it's 0.01 micrograms per deciliter. Is this woman alive? And we're like, yes, she's alive. She's doing great. She's joking about working at TSA.
Right. That's a great case. Wow.
She needs a thyroid medicine started gradually.
Yeah.
And probably a pericardiocentesis. She has
It doesn't
collapsed. She has collapsed, although that's not an
emergency. It doesn't have to be an ER type of thing because she's talking and she's got normal vital signs. So I wouldn't. But that's a remarkable case, actually.
And what was interesting is from the emergency medicine standpoint, she had seen multiple providers at other hospitals many times for fatigue and was diagnosed with a mild UTI, was diagnosed with chronic fatigue, was diagnosed with everything you could think of until they really listened to her heart, realized she hadn't been taking her medication.
Fatigue is a common complaint of people over 50.
And under 50.
And under 50.
And oftentimes you just can't find a cause for it. There's some psychiatric reasons for it. But some subtle medical problems also can do it. And a lot of times the doctors jump on, you're depressed, you don't have any money, no wonder you're tired and feel bad. But oftentimes it is organic, but many times not.
Well, I think that, this is a great case partly because we see weakness and fatigue all the time, all day long. And, even though I'm not an academic, I've had enough experience to really kind of keep that very, very broad. And so when you're working up a weakness and fatigue in the ER, someone who's stable, you do have to have a very broad differential, and you kind of have to do almost, not exactly, but almost a shotgun evaluation on somebody who comes in looking pretty stable, looking pretty normal. There's little subtle findings, and you're just going to pursue, your differential the best you can, and then at the end of all that, that pathway, you hope to make a correct diagnosis and then be able to do the right thing for the patient. Now, in the community, a lot of times you don't have these wonderful diagnoses. You just have this sort of vague, I don't know what's wrong with you. You feel weak and fatigue. But I think it's serious enough that I'm going to either refer you on to somebody as an outpatient, or you just admit them to your observation unit for further study. So that's how I would kind of approach it. But in this particular case, it was actually a very interesting diagnosis as you pursue those little hints that you get from the physical examination and from the past medical history. The fact that she was on thyroid and she was on opiates and other meds should give you a clue, and you have to think about, are they still on it? if they still are on it, are they overdosed on it? Or if they're not taking, are they withdrawing from it? Or they're having effects because they're not on the medicine they're supposed to take. A lot of people don't take medications for their blood pressure even though they're supposed to. So they come in with symptoms because they're not taking their blood pressure medications. So I think this is a good case to really illustrate that, you know, when the rubber hits the road, you really kind of have to think broadly about these very vague things, chief complaints. So that's a great case. Thank you so much.
It was fantastic for follow-up with her. She was so thankful and grateful that we found a reason to explain her fatigue because multiple physicians had seen her, and although they ruled out pretty life-threatening emergent issues, no one could give her an answer. So she was admitted to the hospital, to our inpatient telemetry unit. Cardiothoracic surgery and cardiology were eventually consulted, and they opted to do a pericardial window to drain the fluid and to maximize her management. So she did really well and was very thankful for her care.
Was she more short of breath lying down than sitting up?
You know, even in retrospect, after we knew she had an effusion, we did all this provocative testing, she wasn't really, she's very stoic, she's a very strong lady, and was also thankful that we didn't judge her, given her chronic pain medication use, and anchor and kind of put her into a box.
I did.
My guess,
he's in that box.
My guess is that the infusion built up very slowly over a long period of time. That's why she was so hemodynamically very stable. And that makes it difficult for a diagnosis too, because we're, as ER doctors, you're so used to making the diagnosis of acute etiologies, things that are happening right now and making you have symptoms. But when it's a very slow-growing or slow-going problem, then the diagnosis is much more subtle, and then you have to get the little details of the historian. So I've always said to whoever wants to listen that the devil's in the details, right? So I'm always chasing after the details. My patients probably think I interrogate them, and I don't mean to, but and I always have to qualify and say, you know I sound like I'm interrogating you, but I'm really interested in the details so that I can help you. So that's why I'm asking you for precise times if you can, or how long has this been going on. So I think that's an important point.